Dapat dua assessor hari ni.
Who is 2 years 9 months ago. Currently electively admitted for adenoid tonsillectomy and also bilateral grommet insertion. So from the history, I have gathered a few issues related the problem. The first one is actually achondroplasia. The second one is actually sleep disorder breathing, secondary to mid hypoplasia with adenoid tonsillar hypertrophy. Hydrocephalus, yet I would like to further query regarding the possible causes of hydrocephalus related to achondroplasia, and also recurrent medial effusion, likely related to the underlying disease, and also psychosocial impacts towards the caretaker. So we move on to the first issues is achondroplasia, in which she was first diagnosed when diagnosed antenatally at around 34 weeks as noted sharp long bone, especially at the femur line, and also hydrocephalus. During that time was normal during antenatal scan and further referred to MFM Hospital Sedang. She was born at term 37 weeks via emergency via elective seizure in view of suspect because she is suspected microcephaly at that time. Then subsequently confirmed by subsequently did radiological imaging for further confirmation. Then subsequently were further deferred to HKL and further genetic testing done at 6 months old, confirmed following mutation in FGFR3 gene. Otherwise, there is no parental genetic testing done up till now, and also there is no family history of the skeletal dysplasia. The second one is sleeping disorder breathing. Likely this one is secondary to mid hypoplasia with adenotonsillar hypertrophy. This problem is actually noticed by mother since 5 months old, in which she started to have snoring during sleeping. Apart from that, noted she also had mouth breather and also bleeding cessation. And because of that, she also had easy occurring about 3 to 4 times every night, and further managed in hospital Shah Alams since then. However, there is no proper treatment done there, and then further because of this condition disturb his daily activity and also mother's activity, that's further referred to ENT and also respirating PPUN earlier this year in February 2024. Proceed with the sleep study. According to the mother, the apnea hypopnea index is around 78, which is suggestive of severe obstructive sleep apnea. And since then, she was started on nocturnal CPAP, PIP7 under room air. Significantly marked in symptom, there is no snoring, able to sleep at night, there is no easy awakening at night, and also there is no breathing cessation as well. And regarding the CPAP machine, mother required to rent to the medical social worker, which is about 200 per month. As for now, there is no financial concern regarding the rental of CPAP. However, there is possibility that mother need to buy for CPAP machine, even she need to underwent for the adenoid tonsillectomy. And currently, she is being admitted for adenoid tonsillectomy and will further manage again with the ENT team, and also might need to subject her for another overnight post-oximetry to assess whether she might need nocturnal CPAP even after the adenoid tonsillectomy done. Apart from that, hydrocephalus, yet we need to identify possible cause. I think most likely hydrocephalus related to achondroplasia is likely possible to secondary aqueduct stenosis. However, mother cannot recall the first MRI brain when he was at 11 months old in November 2022. Only first imaging done there was noted some dilatation of the ventricle. However, was treated conservatively under hospital Sungai Buloh. But during the every visit but currently she is asymptomatic. There is no sign or symptom of raised ICP, and also there is no sudden increase of head circumference. Mother cannot recall what is the head circumference, but current head circumference at this admission is 51 cm based on the achondroplasia growth chart. According to the head circumference is at negative standard 2 deviation to negative 1 standard deviation. So apart from that, we should monitor for the other sign or symptom possible of craniocervical compression, in which the child might have further deterioration of gross motor delay, and also lethargic, irritability, or any seizure that need for further urgent imaging, and also further referral to neurosurgical for any surgical intervention. Apart from that, recurrent middle ear effusion, this one is likely due to knowing achondroplasia are usually related to narrowing of auditory canal, and also as because of the severe OSA. According to the mother, child is otherwise able to her previous hearing assessment done normal, in which AABR done recently and do all the finding. However, child did not have any ear discharge so far. Otherwise, this time around, we need to assess again KIP for bilateral rhomic insertion. As for the psychosocial impacts towards the parent, it's much more affected towards the mother, especially as the child was diagnosed with achondroplasia. Mother have to stop working since she is 1 year old. Mother is previously working as engineer, and currently father is only the main breadwinner, which is monthly income is around 4,500. As for now, the financial 4,500 per month, as including to all the rental with the CPAP and also the other equipment that needed. As for now, not requiring for any not requiring for any financial aid from the other things such as zakat, but got help from other family members. Apart from that, developmental. As for now, Aisha Arisa previously showed some isolated gross motor development, but able to catch up. As for now, she started to walk at about 2 years old, and then currently able to step about 2 steps per step, and also climb up 2 steps per step with using whole ring. And also she able to kick a ball. Currently, gross motor is actually able to catch up. Usually had some isolated gross motor delay, as she only can able to walk at 2 years old. The other component of the developmental is appropriate to his age, appropriate to her age. Fine motor is able to copy 0, and also speech motor otherwise is able to talk in sentences about 4 to 5 phrases. Social wise is actually she is able to dress and also dress with her, and also passing play. Apart from that, the dietary dietary intake is actually the weight is actually also not a problem. For the current weight is actually 9.8, which is according to the achondroplasia is around negative standard 2 and also negative standard 1, and also tolerating the normal adult diet, and also milk about 2 times per day. Clinically, she is alert, cheerful, talkative kids, not tachypneic. There is features, dysmorphic features such as she looks small, especially proximal shortening over the humerus and also femoris, with short metacarpal and also short of fingers and also trident hands. There is flat nasal bridge with frontal voicing and also microcephaly. Systemic examination otherwise unremarkable. Lungs was normal as with dual rhythm normal. CNS examination otherwise normal tone with normal power, and also the weight is actually height currently is 69 cm. According to the achondroplasia, growth chart is around negative standard deviation to negative 1 standard deviation. So in summary, Arisha is a 2 years 9 months girl with underlying achondroplasia with complication, and currently is electively admitted for adenoid tonsillectomy and also bilateral rhomic insertion for recurrent middle ear effusion. As for further investigation that needs to be done for her, as actually she is planned to go for operation, so we need to do baseline chest X-ray. This actually we know is actually high risk procedure for her, actually, as she need to go underwent for general anesthesia. So we have to make sure there is no issue with the lung parenchyma, and also we need to do the baseline full blood count, and also to look for HB, and also we need to do for and further management for her actually is involve multidisciplinary approach, in which is involve multidisciplinary team. For the first one is actually especially the genetic counseling. As we know, actually multi is actually still productive age. Both parents are still young, around 29 years old. She is the eldest out of 2 siblings. The current brother is 6 months old, otherwise well. So knowing that actually achondroplasia is about 50 is autosomal dominant, is about 50% inheritance. So that's why we have to to counsel the parents for the possible inheritance next generation, and also to do the screening for both parents. And apart from that, the general pediatrician should monitor his weight and also height, and also especially the head of circumference, which is actually we have to use the appropriate Achondroplasia growth check, because we don't want to avoid for any unnecessary imaging, especially when we see such case with hydrocephalus. But also we have to monitor for the possible of sign of compression of craniocentral junction, compression like possible of deterioration in the neurological function, or any increase in sudden head circumference, and also markedly reduce in developmental delay, and also irritability, in which we need to do repeated imaging, brain imaging, and also need for neurosurgeon brain imaging. As for now, she is going for adenoid tonsillectomy, in which is going for general anesthesia. So we have to we inform to the anesthetic team that actually we have to be careful not to hyperextend the neck, as actually it can risk for possible spinal cord compression due to because of the knowing the anatomy of the Achondroplasia characteristic features have constriction of the foramen magnum. So we have to make sure it's careful manipulation of the neck during the intubation. Apart from that, it will involve the occupational therapy as well. Actually, we know limb, especially in case of the Achondroplasia, is limb shortening interference, especially when to do the step back or any rigid object or feeding. So we can ask our occupational therapy how to add that to use adapting using for any furniture or any school environment, especially when going to school later on, using the lower chair or desk. And apart from that, further assessment also by the orthopedic, as usually as for now the spine examination for her actually not so much an issue at the moment, that there will be a risk for thoracolumbar kyphosis and also lumbar lordosis. That's why, and also January's as well. So that's why we can further clinical assessment by the orthopedic team as well. As general, we also should explain to the mother to avoid any possible activity, especially avoid using the swing or any using the car seat, use the rear facing car seat, because we want to avoid injury especially at the cranial cervical junction.
Yes. Okay. So, alright. Still there is something not fully covered. Sounds like macam cover most of the problems, but there's still few information that I would like to ask. Okay, so to summarize all your punya management tu, what is basically the keyword you have to use when you want to decide to inform how you want to manage this patient?
Multidisciplinary approach.
Don't forget to mention about the multidisciplinary approach. Okay, so about the sleep disorder or SARS and all that. So any evidence of pulmonary hypertension or not?
I did ask the mother, the echo assessment done yearly, but mother unsure of the finding. And also this one also we have to check because this child is going for the operation, also we have to make sure there is no evidence of pulmonary hypertension.
Any symptoms or not?
As for now, no symptom suggestive of any possible right-sided heart failure, because as child just started about 2 weeks, which is started about 2 years old. There's no limitation.
Issue any weight gain and all that?
There's no weight gain. Is actually about the prosthetic.
Clinical examination
also there is no mentioned. It's not lumpy.
So what is the risk factor for her to develop the pulmonary hypertension?
Risk factor for her to develop pulmonary hypertension. Because of the severe OSA, obstructive sleep apnea, so we discuss for the.
Okay, so for the hydrocephalus, so any seizures before?
There is no seizures before. No,
never
had
seizures before. Alright, so developmentally now already catch up.
Yeah, now already catch up. According to my got some isolated close motor delay, especially because just started work at around 2 years old.
For that recurrent MEE, vaccination status?
The vaccination is up to each. There is no additional vaccination like influenza or any chickenpox.
Because of recurrent MEE, from your general pediatrician point of view, does it warrant for immuno-PID screening?
This one, up to this time, I don't think it's need for recurrent. There's no indication for the primary immunodeficiency, because actually there is no prolonged fever. It's mainly because of the yearly screening and all this, and knowing the possible of complication of the underlying disease.
Okay, so I'm gonna ask about some psychosocial punya aspect. How about the parental punya acceptance of this patient punya disease?
For parents, both parents actually well accepted regarding the patient's condition. As for now, mother did worried regarding the possible inheritance, because we knowing that 50% of the possible the next inheritant will have same condition. But because from the mother, because we can detect from antenatal scan easily can be detected, and that's why mother is not keen for the genetic testing. And for now, because of the financial constraint, one of the reason why they don't want to proceed with the parental genetic testing for both parents. But they are still planning. Maybe they are still planning to have another child.
Three siblings.
Now it's two siblings. Currently 6 months old.
Patient is the first child. Okay, so for who's taking care of the patient? Main caretaker
is mother, because mother already stopped working because of the disorder.
Alright. Okay, so macam mana rasa? How long you prepare for this thing? 30 minutes already lah. Okay.
30 minutes lah.
Dah habis dah 20 dah?
Oh, dah.
Okay. So, biasa your practice long case? This one berapa lama prepare ni?
Semalam lah.
Semalam? Tak practice semalam. 1 hour class, then prepare like 5 minutes and 30 minutes present.
I try nak buat 30 minutes sampai tak sempat. I plan to class and also physical examination by 30 minutes tapi tak sempat. So I stand a bit 45 minutes lah. So I get to talk semua then.
Okay. Alright, so okay lah, I think most of cover most of it, then should be okay lah in terms of for long case. So for achondroplasia, yeah lah, I think this one very genetic kind of problem, so you have to know a bit lah. Basically so FG, FRG apa semua tu, waktu semua dominance lah.
Mother told, actually the mother told me the FGR mutation, even I pun tak. But mother is right now
So berapa dia punya cost of the genetic testing? This one FG, FRG ni free je?
Free, yeah. Okay, I asked mother say it's free under HKL.
So for the parental tu they have to pay?
They have to pay.
Berapa?
That one mother tak sure.
Tak sure, thousands lah.
Because actually the financial issue is significantly affected.
So let's say if you want to help that thing financially, macam mana nak buat? Apa option you ada?
Maybe we can first, because actually I have to explore regarding the insurance coverage for the child. Of course, it's not no insurance coverage because of underlying problem. And also when I ask again regarding company from because father is engineer in private company, however, it's not fully covered for the problem medical problem for the child.
Term of assistance.
Maybe we can offer by us help from the zakat, either financial or our medical social worker as well.
I think zakat should cover lah. If you request it, probably they can. If financially not able, it's fine. Especially so kalau condition yang mana yang very indicated untuk screening genetically. Is achondroplasia truly needed?
No, because actually we can detect from the antenatal things. No, SFA maybe. SFA, sorry. Down syndrome.
Down syndrome is straightforward lah. It's what available already. Dapat dua assessor hari ni.
What are the types?
So which type of Down syndrome basically you want to do?
Parental. Because both parents. What you call that? Because there's 3 type of. First is mosaicism.
First is not mosaicism. Mosaicism is
non-disjunction. Oh my god, I can't remember the third one.
The third one is what?
The parental.
Start with R.
Translocation.
Yeah. What translocation? Robertsonian.
Robertsonian translocation.
Robertsonian translocation. So why Robertsonian is very important to screen the parent?
Why it's very important to screen the parents? Yang mana boleh transfer? Yang mana
have high rate of recurrence?
Oh, Robertsonian.
Berapa persen? 50, right? Yeah, 50%.
Depends on why? Because mother is balanced translocation. That's what parents are balanced translocation. That's remember. Balanced translocation, parental balanced.
If advanced age is based on the advanced age, so if more than 35 years old now, is about if the periods of non-disjunction is actually more higher in especially more than 35 years old. But if the mother had the previous child with the Down syndrome and also more than 35 years old, is about 50%, 80% rate.
For
non-disjunction.
So the age tambah 1% because dulu pernah Down syndrome. So tambah 1%. Ingat saja.